All right, folks, welcome back to the Biochemical Genetics Clinical Course Seminar Series. It's August 7th, 2026. This is week 3 of the series for this year. We have the pleasure of having back Dr. Curtis Coughlin, who's going to be talking with us about glycine and lysine metabolism disorders. They're a great set of disorders to know about and a lot of great neurologic pearls and biochemical intricacies there. So just a second, I'll hand it over to him. But first, I want to let everybody know, as per usual, that we have archived episodes at simd.org through the education portal. Those are on their own, well, they're on the YouTube channel for SIMD, so they're accessible there too. And you can stream them one after the other, which is really nice. CME is available, and I'm posting right now in the chat, and I will a couple more times. The CME code is here. I've talked with the folks at the CME office at Children's, and if you are not able to or don't want to pay for the AMA certified CME, you can get a certificate of attendance. It doesn't quite count the same, but you can get that for free. But you have to email Jade Freeman. So I'm gonna her email's right here in the chat also, but I'll make sure that that's available a couple more times throughout the session too. If you want to email her, let her know you want a certificate. Um, Free certificate of attendance. But I encourage everybody to go to the link, put in the code, etc., just to evaluate the session and let us know how you think things are going, both with the seminar series as a whole and also for Dr. Coughlin. And yeah, we're always happy to get feedback, and it just makes the series better. So I think with that, I will hand it over to you, Dr. Coughlin, if you want to get started.
Yeah, thanks so much for having me, Dr. Baker. Pete, this is always one of the highlights of my year, getting to talk about things that I care a lot about with mainly new trainees. I hope that the level of detail in these slides are sort of what most people want. I'm happy to talk about things in more detail. Also, there are really much smarter people on this call than me. Like I saw Dr. Barshup and Drs. Tim Wood and Janet Thomas already joining. So if they have comments too, ask questions. If it's something I don't know, maybe our esteemed colleagues will. I sort of left time for questions at the end, but I'm happy to stop in between. I also want to mention that Pete kindly lets me talk about things that I have focused my research career on for the last 15 years. So I show a lot of papers of things that we have done, but it also sometimes worried that makes us biased. We don't think we're the only ones who have good information about these disorders. So if you feel like I am a little too biased in that, let me know. So most of today, I'm really going to focus on a disease specific approach to glycine and lysine metabolism. We're going to look at biochemistry. We're going to look at pathways. I was trained in a biochemical lab under Steve Goodman. I love biochemistry. I assume that's one of the things that we're all here for, but I really want to highlight the disorders that are common and sort of the current treatment approaches for all of them. We're going to start with disorders of glycine metabolism. Um, this is a lot of work that I was lucky enough to do with Dr. Van Hove early in my career. I should say Pete also did some of this work when we were both sort of junior in Dr. Van Hove's lab, and a lot of this really comes from him. So when we think about glycine metabolism, one thing I like to think about every pathway is sort of the details that I do want to know, but also some way for my mind to wrap around really what's happening, or as I like to call in a couple of my slides, sort of this simplified view of how glycine is broken down. We're going to look at the actual pathway a couple of times on the right, but just as a starting point, I want to remind us that all of metabolism is very interconnected. And specifically, this part of metabolism, the interaction between glycine, single carbon metabolism or folate metabolism, and methionine and serine are all very closely linked. And it's going to be really hard to think about your patients from just a glycine only approach. And as we start to get towards sort of upcoming therapies, we also want to think about how our genetic defects that cause our patients to have elevated glycine impact at least these three related pathways. There are a lot of things that cause elevated glycine. This figure is from a review article that was written here by us in Colorado and some colleagues in Australia just last year. And really, we're trying to emphasize a couple of things that if you have a patient with elevated glycine, you should think about more than just maybe NKH, which is what we're going to spend most of our time talking about today. And also, we all love our genome sequencing, and sometimes you're going to get back negative genome results, and you think, oh, this is an exciting opportunity to find a new gene associated with glycine elevations. A reminder that a lot of other things can cause really high glycine elevations. Some of the highest we've ever seen are actually right after a patient's received IVIG infusion. Certainly, sky high levels of glycine. Some of the medications that I think all of us in metabolism think about, like valproate, can secondarily inhibit the glycine cleavage enzyme, and you see elevated glycine. And then a couple of other just genetic disorders that you're going to think of, like some of the organic acidureas, and this one that's a little bit more rare, HCFC1, which is a disorder of cobalamin C regulation. So we hope this figure sort of helps you think about like if you have a elevated glycine, all the things to think about. I'm actually a big fan of the JIMD podcast, and maybe it's because they've invited me on quite a few times. But Artie, the first author of this article, and I did a podcast just recently talking through all of the variations of glycine. So I'm sure what all of you want to do as you drive home or go for a run is listen to more about metabolism. But if you have a patient with elevated glycine, we try to do a good job on this podcast, just walking through a simple algorithm of what to think about. Here's another way of viewing just some of the genetic causes of elevated glycine. And by far, the single most common reason to have an elevated glycine is disorders of the glycine cleavage system, or NKH. And since it's the most common reason, that's really what I'm going to talk about for the next 10 or 15 minutes. But during the question answer time, or if someone has a question about one of these other disorders that cause elevated glycine, more than happy to share my expertise or anyone else on the call. So this is a picture from that same review article that I just mentioned, showing the glycine cleavage enzyme. And so the ones here in the, I don't know, we think this is mauve or pink on and outside of the gray box, we'll call it the GLDC and AMT are the two genes most associated with NKH. GLDC is by far the most common outside of Spain, really, and there's a high founder effect of AMT in Spain. So as we go through this disorder, we're just going to review a little bit of the biochemistry and the clinical aspects. We did the biochemistry already. So I think this is what most of us think about when we think of NKH, especially if you've only seen one patient. This is probably you've seen a very severe or classic form of NKH, or if you've never seen a patient, this is probably how we teach it. Most of these children present with really significant lethargy or poor feeding right at birth. The vast majority of children need have difficulty with respiratory effort and end up in an apneic coma and require ventilator support. For reasons that are becoming a little bit more clear, but still a little unknown, this is a really transient period of time. Over time, the patients are able to breathe over the ventilator and no longer need that kind of support. You can, how long they're in this apneic coma is usually it can be days to weeks, and that period can be shortened if you recognize that the reason they're in an apneic coma is from NKH and you treat them aggressively. It is a period of time that many families have conversations with you and other colleagues about withdrawal of life-sustaining measures, and it's a really significant, vulnerable period of time. Also, really early on, these patients with severe NKH, that they have pretty significant intractable epilepsy. And in fact, over the course of their life, the epilepsy becomes almost impossible to manage. Certainly, we'll talk a little bit about some of the ways to manage the epilepsy. And through that course of the neonatal time to childhood, Most patients with this severe form of NKH, they're going to make really minimal developmental gains. They're not going to be able to sit up. They're not going to be able to grasp and hold objects. They actually will have cortical blindness over time, and you'll see some sort of orthopedic, the scoliosis and hip dislocation also over time. Although this is the most common presentation of NKH that is probably still seen, there are also patients who have a much more mild form of NKH, or what Dr. Van Hove likes to call attenuated phenotypes, where you can have various levels of developmental outcomes. So this graph, we're sort of basing it on sort of your DQ or IQ range, where patients can make developmental gains, can have some ability to walk and talk and make those cognitive improvements. The more milder you get, the less often seizures are present, or seizures become really easy to control with traditional anti-seizure medications. And what's becoming more and more recognized is that there's a really incredibly mild form of NKH where patients have slightly elevated glycine in their blood and CSF. And we're really talking just barely over sort of your lab's reference range. And those children and at least one adult seem completely cognitively normal. They sort of do have some metabolic decompensation when sick. We know of one patient who has some hallucinations when ill, but it is by far can be an extremely mild end of the spectrum for NKH. I think it's really important when you are the clinician taking care of those patients in that first few moments of life, or even during that apneic coma, to recognize that there is this huge spectrum of phenotypes. And um, unfortunately, even some of the very mild patients can end up in an apneic coma. So that alone is not stating that you have severe NKH. I will say the opposite, that none of the severe patients will sort of skip that apneic coma stage. But again, just reminding that it can be really mild. I enjoy pictures and movies, as maybe you can tell. I enjoy the volume of the movies less, so let's start that over. This is from a patient association meeting that occurred. And so this girl that's walking around has a mild attenuated form of NKH. I mean, you can see her that she is not completely normal, obviously, but much different than the kids with the severe NKH at the same meeting in the wheelchairs. Actually, this young boy she's interacting with now has a fairly mild form of NKH. So again, just recognizing that even in this disorder, there is quite a significant spectrum that is possible with our patients. So thinking a little bit how we diagnose NKH, uh, one thing that, again, I think we all really love are quick and easy genomic sequencing. That's not always possible everywhere in the world, and it's not always possible really quickly. MRI-based imaging is really helpful to make a diagnosis early. Yeah, we see we have one question already. Go ahead.
Thank you so much. Something I wanted to ask about is regarding these different variability in the disease severity. Is that can we predict that based on their variant or anything else, or is it just based on how the patient really
Yeah.
develops?
Such a good question. The reason I kind of paused in my talk was I thought I put all of the prognostic factors right after the phenotype, but instead I put them in a couple of slides. But we spent a lot of time trying to help clinicians be able to predict their phenotype. So let's see if those slides help, and if not, I'm happy to jump into more discussion. Actually, the MRI can help a little bit. If you have structural malformation on the MRI, then again, you know that that patient has a severe form of NKH. One thing that I really appreciate about this one paper that we published out of Colorado here again is it really did show that this disorder is progressive. We see changes over time. And maybe that's different than how I was taught about NCAH 20 years ago, when I was trained outside of Colorado, thinking that like this is a disorder that doesn't really have a window that could respond to therapy, like in utero damage, these kids come out really sick, but they do. These MRI studies show that there's still a progressive nature to the disorder, and really there might be a time, a window where therapeutic approaches could really benefit patients. So again, MRI can help you make the diagnosis. MRS is really very sensitive, can also sometimes help you think about sort of the progressive nature. What a perfect time to jump into the predictive part of this. This was really a study that maybe the study I'm most excited to participate with Dr. Van Hove's lab is our hope was try to help clinicians figure out if these patients were very severe classic NKH or possibly have a mild phenotype, and really trying to look for things that could predict this at birth. Those first few days of life when a child is in an apneic coma, and you might want to be helping patient parents think about treatment decisions and whether or not this clinical course is going to be severe or mild. There wasn't one perfect predictor, as you can see from this paper. A lot of things can help, from biochemical findings to the brain malformations on MRI. Definitely the genetic testing, I think, can be the most helpful. There are quite a few variants that just have a whole lot of residual enzyme activity. And like most metabolic diseases, a mild variant, mild enzyme activity often results in a mild phenotype. So getting that genetic testing early is probably one of the things that helps the most in your prediction of whether or not this is likely to be a severe or more mild form of NKH. Biochemical testing can sometimes be helpful. This is an old figure that I'm showing here from newborn screening study done in California that just sort of reminded us that a lot of newborns have elevated glycine in blood or in plasma. In this study, they're showing all of the patients here in blue, and then the red arrows on the bottom are the patients who actually did have NKH. And it'd be nice if all of those red arrows were all the way to the right, and you didn't see any patients with elevated glycine who did not have a glycine encephalopathy. But certainly was not true, and one of the reasons that California paused or stopped newborn screening for NKH. In general, it's a pretty good biomarker. It's just not something that you can rely on by itself. CSF glycine is much better. We want to highlight the fact that the mild end of this spectrum, you can see normal plasma glycine. You can also very rarely, I think we know of two cases that have normal CSF glycine. And again, these are the most mild end of the spectrum, to the point where you can start to ask yourself, where is the line between having a disorder that you would call NKH and sort of normal variability in anyone? But those really mild glycine levels are possible. Biochemistry is a good biomarker. It's just not perfect. Dr. Van Hope specifically, this is not work I was involved with him at all, but I think really exciting work. Tried to look at all of the metabolites that are sort of interrelated. So we go back to that first pathway figure. I'm highlighting here how closely related serine, glycine, and threonine are to each other. And sort of this question of, glycine we know is not perfect. What if we were to measure all three of these? Could some variation of the three of these, or the ratio of the three of these, sort of help us do a better job of diagnosing NKH or predicting severity? I think this is a lot of really good data that I'd be happy to talk to anybody about, and I'm sure Dr. Van Hove would love to spend time talking to you about. I think the takeaway message is that it can help at times, and there are still some overlaps between the most severe and the least mild patients, and the patients who are the most mild are sometimes hard to tell. And I think all of us would say that if genetic testing is available, it's often still the most helpful and most predictive if we know what that variant does. Genetic testing is really good. This is a paper of ours from 2017. There's been a lot of other papers. One just came out last week that was similar to this. In our original paper, we did almost 600 families looking at variants in GLDC and AMT and tried to sort of help classify variants based on the severity of the disease. There's some really good mutation repositories coming out that are trying to be predictive of phenotype. They are not publicly available yet, but I think they're coming out this fall, and maybe we can send that out later of where to look for those. But genetic testing is really very helpful in this disorder, like most disorders. So current treatment of NKH, I really want to separate sort of current treatment and sort of upcoming treatments for all three of these diseases. We talk about how this is a disorder of glycine metabolism, and the primary treatment is reducing glycine. That's still mainly done with sodium benzoate. It's been used for a really long time, both in urea cycle patients and in patients with NKH. It's a pretty safe medication. There's very little risks. There is a small risk for benzoate toxicity. Basically, if you're giving more benzoate and there's no glycine there for it to conjugate. But for patients with NKH, usually have so much glycine, that risk is very, very low. The other way to lower glycine is the ketogenic diet. Basically, you're taking all of the glycine from the diet out. That really can help. I mean, you're really eliminating all of it. Also, there's a secondary benefit of the ketogenic diet helping improve seizure activity. Um, the most severe patients with NKH who've gone on ketogenic diet can still have difficulty to control seizures, but certainly it is a way to improve two aspects of the disorder. If you do start a patient on ketogenic diet who's already been on benzoate, you have to really be conscious of the fact that you're squeezing out the glycine. And so you want to make sure you lower your sodium benzoate. And as everyone I know who's on the ketogenic diet is still on some level of sodium benzoate. For a very long time, Dr. Van Hove and others have recommended NMD receptor antagonists in this disorder. Maybe the one most used in the US is dextromethorphan, and the one most used in Europe had been ketamine. Um, Newer results have sort of suggested that dextromethorphan and ketamine actually have an adverse effect on patients. Here's a paper from Dr. Van Hove from a couple of years ago. And you might notice some of the more recent guidelines have actually recommended to stop using this treatment. And I don't think this has always somewhat been controversial, the benefit of these medications, but at this moment, most clinicians will just use sodium benzoate as a treatment for a ketogenic diet for NKH. Um, I was going to talk briefly about some of the upcoming research studies, but if anyone has a question about clinical care things, throw it in there and we'll see if our colleagues have any things to add too. Like many metabolic disorders, when we just think about general tenets of treatment, like I'm sure that you have in your first day of training in metabolism, one of the things we think about for sure are cofactors of our enzymes, and that sometimes those cofactors can also work as chaperones. There is some case reports of patients with a mild form of NKH who, when they received paradoxal 5-phosphate, which is the cofactor for this enzyme, did seem to do better developmentally, both mainly from subjective reports. But certainly, I feel like this is something that a lot of families have talked about with each other and gets brought up a lot about the use of paradoxal phosphate. Like any metabolic disorder, this is probably mutation specific. Some of the mutations may be ones that change the binding pocket for the cofactor, really seem to respond well in the laboratory to P5P and others don't. As someone who spends most of his career focused on B6 vitamins, I just want to say that P5P has a risk with it. We're going to talk about it in the next section, but there's a real risk of liver dysfunction and even hepatic cellular carcinoma with P5P. So, although there are these case reports of it working as a chaperone, I think you need to think about the risk of providing P5P if you ever consider it for patients with GLDC mutations. Like most metabolic diseases, there's been a lot of work on gene therapy. And so this is a now 2-year-old paper from Nicholas Green's lab in the UK. And what they showed is that this intracerebral ventricle delivered AAV gene gene therapy can lower glycine in the brain of their NKH mouse. Um, this work is ongoing, although not a ton has been published in the last 2 years, but certainly it seems like this in an animal model seems really promising as a gene therapy approach in NKH. If any of you have been at some of the more recent, either the ICIM meeting that occurred last summer in Japan, and there's a talk this year at SSIEM in a couple of weeks on some companies that have also developed a gene therapy approach to NKH, again, all done in preclinical models, but certainly seems to be really exciting that there might be a gene therapy based treatment for this disorder, at least in clinical trials coming soon. Um, Highlighting some work by Dr. Van Hove here in Colorado. This is all his work that he shared with me, I think, yesterday to share. But thinking about how these pathways are really interconnected and the fact that most of our traditional therapies, all we're really been focusing on is reducing glycine and not really paying attention to the impact on single carbon metabolism or on sort of the methionine that occur, the depletion that occurs. This is actually a pretty old paper now, 9 years from Nicholas's Green's group. But in their encaged mice, they treated their mice with methionine and really showed a significant improvement in their mouse model. Now, the mouse model isn't perfect, right? None of our patients are mice, and what happens mainly in their mice model is they get really significant neural tube defects. Um, and so the methionine supplementation in that knockout mouse model was able to rescue the neurotube defects, but sort of a proof of concept of how important methionine restoration may be in this disorder. This was shared by Dr. Van Hove, as I said yesterday, that this is unpublished so far and observational, but he has treated a couple of patients with methionine and benzoate in the first few weeks of life. And so far, all of those patients treated early in life have seen a really significant improvement in the seizures. Um, Patients, again, with classic NKH have really intractable epilepsy. There's been no magic anti-seizure medications, plural polytherapy that has really seemed to help. And on those patients who are treated with methionine, they have been able to treat their seizures. Um, so far, these kids are still kind of young, but no evidence of cortical blindness, and development has been slightly better. And the one who's been treated the longest, still not able to really sit up on her own or grasping and holding objects, but has been able to interact a little bit more, roll a little bit more, and have some head control. So really early observational studies. I know that this work is ongoing, and if you have a new patient with NKH, certainly something to reach out to Dr. Van Hoef for. I'm going to transition to lysine metabolism, which is what my and my work has primarily been over the last 10 years. And I know that I have a tendency to be super excited about this first condition, so I'm going to try to keep it short and not feel like I'm making everyone think that pyridoxine-dependent epilepsy is the coolest metabolic disease there is. But studies are showing, people are saying that it is the coolest metabolic disease. So we'll at least hit on it. So just as a reminder of lysine metabolism, this is a really narrow picture of what happens in lysine metabolism, but that lysine in humans gets degraded through a couple of different places, like in the cytosol, in the peroxisome, and then mainly in the mitochondria. But like sometimes we forget about these other ways that lysine is degraded. Ultimately, like most things, it gets degraded in the TCA cycle, and that there's two relatively common metabolic diseases that we're going to talk about today. The one that we all know really well, I assume, is glutaric aciduria type 1, which is here in yellow. And then one that uh, we'll talk about first, paradoxine-dependent epilepsy, that is a little bit more proximal to lysine itself. There are other defects in this pathway that we as a community have focused on at times, with some question about whether or not there is any impact on patients. The first two steps in lysine metabolism are both due to a deficiency of the enzyme AASS, and they could cause an elevated lysine, which we refer to hyperlysinemia, or they can cause an elevated saccharapine and lysine together. There is growing evidence that that second step might have a mild phenotype, more like a Charcot-Marie tooth-like phenotype. Um, and then right before G1, there is an enzyme called DHTKD1, which for a long time has again thought to be a relatively benign biochemical condition. At least in a mouse model, there are some symptoms of some neurologic dysfunction. I put these in gray because, in my personal opinion, I don't feel like there's a lot of evidence that these are disease causing, but I'm happy for one of you to disagree with me and just point out that these are defects that we have seen in patients, that they can have really specific biochemical findings, and maybe you or your lab colleagues might, report out the fact that someone has hyperlysinemia. So I'm going to start with paradoxine-dependent epilepsy, not because I love it the most, but because it's the first step in the pathway that we're going to talk about. And so in paradoxine-dependent epilepsy, we have an elevation of some biomarkers that provide a good chance for us to make a diagnosis, AASA and P6C. Also, the elevation of P6C is what causes these patients to need B6. It is a secondary deficiency of B6. I know that I don't need to explain this to this audience at all, but like this is what metabolites do. These are what molecules do, right? As they bounce around with each other, they sometimes interact with other molecules and form reactions. And so it just so happens that P6C forms a reaction with the bioavailable form of B6. And the consequences of that is that you have very low levels of B6. So if you were to test one of these child's CSF paradoxal 5-phosphate level, which is what we've done many, many times as for a diagnosis, you will see that they have almost no paradoxal 5-phosphate. And so one of the therapies for this is to continuously give B6. We're just constantly, daily trying to overcome this secondary deficiency of paradoxal 5-phosphate. So just to think a little bit about this disorder, it's mainly was described for decades as primarily a seizure disorder. In fact, the prevailing thought of this disorder is that everyone started to seize at day 0 of life, that none of those patients ever responded to B6, and that the first time you ever gave a child B6, like magic, they would stop seizing. Maybe you can tell some level of sarcasm there, that none of that is completely true. Although a lot of kids seize on day 0 of life, half of them seize after the first day of life. In fact, some children respond to anti-seizure medications, usually not that well. The story we hear is like they responded to a seizure medication for a few days and then they didn't, and they kept trying different approaches and with always some mild success to control seizures. The other thing is that not every child responds immediately to B6. In fact, only 20% of children will stop seizing the first time they receive B6. We recommend that you trial B6 for 3 straight days if you were going to do a trial of B6. And certainly not every child seizes at birth. Here's just a couple of case reports of kids who have their first seizure at a few months of life, a few years of life, into adolescence, and the oldest so far that we know of was 17 years old when they had their first seizure with PDE. Something that always drives me crazy about these papers, I hope this is if this is one of you on the call and you wrote these papers, I'm sorry to criticize, but they all say that the patient presented with their first symptoms at 17 years of life with a seizure. But that patient had really significant intellectual disability and developmental delay as a result of PDE and presented to care and with those symptoms throughout life. And there are a lot of symptoms of PDE. Some of the ones I think that maybe we don't talk about enough, but that's important for this audience is you can have some really significant lactic acidosis, hyperammonemia, hypoglycemia at birth, often leading us to think about other disorders, other energy metabolism disorders. The speech and language delay and is really significant. Almost every patient has really delayed speech and language development. But certainly, what our group has focused on the most is the intellectual disability in this disorder. Um, Overall, the average IQ for patients with PDE is just under 70. Um, we certainly know patients who have IQs much lower and some patients who have subnormal IQ. This has always been true. Going back to the very first description of this disorder at CHOP in 1954, this was a patient who received B6 the first days of life. Just uh, accidentally almost received B6 and stopped seizing and was described as markedly retarded or significant intellectual disability. In every study that has been published, we sort of seen this consistent intellectual disability. Usually, when I'm giving talks about PDE, someone always says to me, well, that's just because the seizures are poorly controlled. If you could have treated the seizures better or earlier, development would have been normal. And certainly, there are quite a lot of patients who are second siblings born to a family. We often treat those moms who are at risk to have another child with PDE with B6 antenatally. Those patients almost never seize who receive antenatal B6, and it's continued after birth. So no evidence of seizures, no EEG, abnormal EEGs. And despite in utero treatment, we still can see some pretty significant developmental delay. Here's one paper from Vinius Bach's group in Amsterdam, and they showed long-term IQs of 35 to 60 in 4 of their patients. We also published a paper a couple of years ago looking at 18 families that all had multiple affected children, and none of the younger kids who we all knew about the diagnosis treated either antenatally or right at birth. They all had the same IQ as their older siblings who seized for days, weeks, months, and years. So, although I appreciate the fact that maybe we could still treat seizures better, certainly the intellectual disability is not tied only to the seizures in this disorder. This is actually a picture from 2 weeks ago at our family retreat. This is 30 patients with PDE who came, and I think one of the reasons I was really fun to show this picture is that we really had quite a few adults with PDE here, not just these young children. But you can really see that this phenotype type is really, really wide from patients who may be able to live on their own, although only one of our adult was living on their own, um, with some behavioral problems to some more significant intellectual disabilities. And like every disorder, there's quite a phenotypic spectrum of this disorder. Um, I mentioned that I always enjoy biochemistry first. I always will, and doing biochemical testing to identify this disease is really good. It's probably the way that we recommend doing it in our consensus guidelines. And the primary biomarkers for diagnosis are the AASA and P6C. One caveat for this is that these metabolites degrade really fast at room temperature. Your samples really have to be drawn and stored on frozen and shipped on dried ice to the laboratories that do that. I know that's not possible for everyone around the world, and that sometimes you get back results that can't be reported to you because the samples have been sitting, but these are still really good biomarkers. About 10 years ago, my lab really focused on trying to find other biomarkers that could be utilized. And we, 2019, published this biomarker called 6-oxopipicolate. And then in 2021, the group in Amsterdam published this other one, 2-OPP. The nice thing about both of these biomarkers is they're incredibly stable at room temperature. I mean, for our publication, we just left samples on our lab bench for months and measured them every couple of days. If anyone was at SIMD this year, our lab presented our work on newborn screening for this condition using these two biomarkers. And we talk a lot about newborn screening for this condition, but also these are just good diagnostic biomarkers for any patient. If you're in the United States, I believe the Children's Hospital of Orange County offers 6-oxopipicolate as a clinical test in urine. Certainly, if any of your patients are enrolled in our research studies, we do both of these biomarkers for all of our research studies, and we hope that the University of Colorado or Children's Hospital of Colorado will maybe have these as clinical tests coming soon. In Europe, you can get these as clinical testings in Amsterdam and in the UK at Philippa Mills's laboratory. I mentioned that we've done a lot of work on newborn screening for this condition, and we're really excited about the possibility of newborn screening. This was our paper in 2025 that suggested we could identify patients with PDE on sort of routine flow injection. Everybody does newborn screening, and really shortly thereafter, a couple of labs published very similar papers using our methods to show that they were also able to identify these patients compared to other newborn dry blood spots, just suggesting that biochemical-based newborn screening for this condition certainly seems possible and exciting. I want to make sure there's no questions. Doesn't look like there is any P, sorry. Similar to our NCAGE paper, we published almost 200 patients with PDE just to look sort of like, I don't know, is genetic testing good? And the answer is it's quite good. 98% of patients we were able to find disease causing mutations in the ALD7A1 gene. We're excited that we've been part of most of the genomic-based newborn screening studies around the world. I believe in June, the 11th newborn was diagnosed on one of those genomic newborn screening programs. So we're just excited that anybody is getting diagnosed at birth. Something I don't think I highlight enough in these talks is that as we meet families over time, the number of children who have died because no one recognized that they had PDE and died as a result of uncontrolled seizures is quite astounding to me. And so, any way that we can identify these kids and make sure that we can provide really life-changing treatment through giving B6 is important. So, genetic testing also really good. So a little bit about treatment of PDE. Not surprisingly, we do talk about seizures and the importance of paradoxine in seizure treatment. Maybe someone's awake enough on a Friday to notice that I mentioned that this is a secondary deficiency of paradoxal 5-phosphate, the active form of B6. But we recommend treating every patient with paradoxine. And that's really that paradoxal phosphate is really has quite a significant risk to it. There's a nice paper by the group in Boston, but led by Philip Pearl and the group in the UK, by Peter Clayton this year on the risk of hepatic cellular carcinoma with chronic paradoxal 5-phosphate supplementation. It's been known for a long time that patients can get sort of a significant transaminitis as a result of paradoxal 5-phosphate, leading to cirrhosis, leading to some children who've even required a transplant. We're still not completely sure what causes the inflammation. I think most people believe it's due to the impurities of the way that paradoxal 5-phosphate has been manufactured at various labs, but no one's really quite sure. In those recent paper of all of the children who developed hepatic cellular carcinoma, there are three different genetic conditions that were all treated with paradoxal 5-phosphate. So we really think that the risk is related to paradoxal 5-phosphate. Meanwhile, paradoxine is pretty cheap. It has a relatively low risk. If you have high dose paradoxine can cause neuropathy. If we have any colleagues in Australia on the call, I know there's been a lot of discussion in Australia about banning B6 in general from individuals who've developed neuropathy by taking high dose B6 supplements. There's a lot of B6 in energy drinks. But certainly the amount of B6 that we recommend our patients on should not have any neuropathy. Also, the neuropathy is reversible, unlike the hepatic cellular carcinoma. In our larger scale studies, it's been somewhere between 95 and 96% of patients remain seizure free just taking paradoxine. Almost all of the patients who require an anti-seizure medication, in addition, it's really due to some scarring that occurred during their early epilepsy events and not really due to the disorder itself. So paradoxine really safe. Every patient should be on it. I hope I highlighted that there's other things besides seizure in this disorder, and that some of that is intellectual disability and behavioral changes, ADHD, autism spectrum disorder. And our leading hypothesis is that this is sort of a chronic intoxication disorder, a chronic exposure to these abnormal metabolites. And our evidence for this chronic exposure is mainly done based on a lot of preclinical animal models that I'm not showing here, but happy to talk to anybody about like how much evidence do you have that it's one of these metabolites. And so for about 15 years, many people around the country have tried these lysine reduction therapies. And we in Colorado co-led the first two studies and tried using just formula for GA1, trying to reduce lysine reduction, and then added arginine as a competitive inhibitor of lysine transport. That competitive inhibition occurs in the gut and in the intercellularly and across the blood-brain barrier. Some really good work from the group in Vancouver shows that this competition only happens um, within a short time window when you take both arginine and lysine together, which means that if you have a patient taking arginine before bed while they're not taking their lysine, it's really not doing anything. If you were to give a patient citrulline instead of arginine, it would not convert to arginine in the gut prior to its competition with lysine. Again, those studies were really based on some isotope tracer studies, and so the timing of this is really important. For those of you who are old enough to have treated PKU patients with large neutral amino acids, that was true of that too, right? We really timed the large neutral amino acids with natural protein. In those studies, we showed that all of the patients on lysine reduction therapy made their biochemistry levels a lot better. So it made us all feel good, right? Like we intervened with patients. In the top, we sort of followed patients over time and we changed them from a normal diet to lysine restricted diet. And we saw a reduction in metabolites. In the second study, we did pre-post studies. So the yellow one is just on B6 only. The pink one is on the diet only, and B6, and the blue is arginine. And we saw with each therapy, we reduced their metabolites. We're a little worried that all we were doing is improving biochemistry and not making a real difference in patients' lives, although we had some anecdotal evidence that we were making patients better. Here's a patient in our second study who really had a significant developmental change after being on what we called triple therapy. And a lot of studies have come. I lost track anymore. It's over 25 case series in this period of time of people being treated with lysine reduction therapy. And everyone said their patients seemed better. I think the thing that our group, the International PDE Consortium, maybe might be most proud of is this is a 10-year study that we published in 2022, led by the members of the consortia. And we assigned patients into cohorts based whether they were treated with B6 only or if they were treated with B6 plus lysine restricted therapy. Our general outcome measure was IQ, which is not everything about a child's development or cognitive development, just one measure, but certainly a good measure to look at. Um, and what we saw was that on average, patients who were treated with the lysine reduction therapy had an increase of 7 IQ points that was not statistically significant. And this is kind of what we expected. If you remember the early PKU studies where they looked at IQ being on a phenylalanine diet, they didn't see any difference. And that's because they just took any patient with PKU and put them on a phenylalanine diet. And we looked at this data that same way. We took any patient. We had one patient in this cohort who was 16 years old who switched cohorts into the lysine reductive therapy one for 6 months and didn't see a benefit. And I don't exactly know how old you have to be to start treatment or how long, but certainly that was less than ideal. The goal of this study was actually to look at the benefit of early treatment with lysine reduction therapy. So in this figure, I'm showing IQ to patients who were treated early in life with B6 plus lysine restrictive therapy on the right. And on average, we saw a 22-point IQ increase in patients who were treated in the first 6 months of life. Now, we weren't powered to look at patients treated at birth or in the first week of life. Like we hypothesized that if you could treat patients at birth, that the results would be better. But this was showing that if you could treat patients in the first 6 months of life, we see a really difference in IQ. Anecdotally, we also see the same thing. Those patients who are treated in that first week of life seem to be the same as their unaffected siblings. Going back to these family meetings, you can quickly figure out the patients who were treated with lysine reductive therapy in the first weeks of life versus all the other teenagers and adolescents. And again, anecdotal evidence for the first week of life, but that paper suggests we really are improving outcomes in the first 6 months. Based on that data, we've published more recent consensus guidelines. This is from 2021. And basically, the new guidelines, I tried to summarize them really briefly here. They're quite long, but the goal is that all patients should be treated with B6 regardless of what other therapy you're on, and that really almost all patients should be on some lysine reduction therapy as well, whether that's a lysine restricted diet, a protein restricted diet, or arginine supplementation. We also published a paper, a standalone paper that tried to explain a little bit more on how the diet should be done in PDE and is this diet different than in GA1. This really article was written by some dietitians, mainly for dietitians. That's the audience, but I think it's really good overall. And we've done podcasts on both of those papers if you are that person who just wants to listen to the treatment recommendations or the dietary management. Maybe you can tell I'm most excited about our work in PDE, and I'd be more than excited to talk to any of you about any of your patients with PDE ever or consider our research studies. But I was trained in Dr. Goodman's lab and spent all of my time in his lab talking to him about glutaric aciduria type 1, and still a big focus of what we do, and something I hope that everyone on the call feels very familiar with. This disorder was described back in 1975, sort of a classic organic aciduria, and again, in lysine metabolism. Most of us think about this disorder and think about this really life-altering striatal injury that can occur. We know that this injury almost often occurs in the first 3 years of life. Although patients who've had a striatal injury in the first 3 years of life can have ongoing or worsening injury up until age 6. Still to this day, I don't know any patient who's had a re-injury of the striatum after age 6. Every year, someone tells me they think they have a patient that does, and we look at it with a bunch of colleagues and we don't see evidence of that. Happy to talk to you if you know someone who's had a new injury or re-injury after age 6. We usually think about this injury in two different contexts. The one that all of us are most worried about is this illness, right? This small febrile illness, not eating well, and you have this metabolic crisis. And it was the most common cause of a striatal injury. Because the metabolic community is so good, it's actually changed that the most common reason patients have the injury is what we refer to as this insidious onset, or looking back, no one can identify a fever or a period of time where their child wasn't eating well and they still have this striatal injury. And it's about 10 to 20% of, used to be 10 to 20% of patients who have an injury. It looks like it's shifting again, that most of the kids today who have a striatal injury occur because of this insidious onset. Um, when we're talking, just to highlight what we're talking about here, we're really talking about an injury of the striatum within the basal ganglia. And I really want to be specific that we are talking about this only when we're talking about the neurologic injury prior to age 6. Still occurs. Here's a picture from our most recent Organic Aciduria Association meeting, and you can see one of our patients in a wheelchair. Um, our lab is actually really focused on how often this still occurs, and looks like it's somewhere around 10 to 30% of patients today who have a positive newborn screen, who are treated well by a metabolic group, still have a striatal injury as a result of GA1. That's different than pre-newborn screening, right? Pre-newborn screening, it was almost all of patients, somewhere around 90 to 95% of patients had this devastating striatal injury that resulted in a significant movement disorder. That's how patients came to care. Almost all of those injuries that were reported were due to this an illness of some sort in that vulnerable window of 0 to 3 years, although a small percentage of those old papers also suggest patients had an insidious onset. After newborn screening, it still occurs. It's a bad disease. It needs better treatment, but it's much less. Now, only about 10 to 30% of patients have that striatal injury. We still sort of notice again that there's more patients with this insidious onset than before. Everyone always emails me after this talk, and I love it. Thank you. To say, like, Curtis, obviously neurologic injury still occurs post age 6, and it does. In fact, that is mainly what our lab is interested in, is the neurologic phenotype of GA1 post age 6, and they can be very significant findings post age 6, but they don't involve the basal ganglia. And that's the real separation at age 6. In fact, we hope to have a paper out soon about how many patients actually develop epilepsy. It's quite a high percentage of patients will have seizures, with the average age of onset with seizures is age 12. And you can have seizures all the way up into the sixth decade of life, like new onset seizures. You can have other strokes that occur that are not involving the basal ganglia. You can have ataxia-like episodes, develop cerebral palsy. The neurologic dysfunction post age 6 is significant. And I don't ever want to like downplay it. It's just that it is not the same striatal injury that happens pre-age 6. And so we like to refer to this as extra striatal symptoms. I don't know if we feel like there should be a better word to use, but certainly there are still significant neurologic findings that occur over time. The other thing that I think all of us are recognizing and never really have a lot to explain it is that there is fairly consistent kidney dysfunction in patients with GA1. I'm using the word dysfunction very purposefully there. There's not a lot of adults that you would describe as having kidney disease. In the literature, there's only 2 patients who've ever required dialysis, for example, and both of those patients, it looks like there were other contributing factors to why they had dialysis, but it's pretty common for patients to have kidney dysfunction and quite young to show kidney dysfunction. Like 5, 6 years of age, you can see the kidney dysfunction in some patients. There's also a small group of patients that people refer to as adult onset, meaning that they've had no symptoms until the third, fourth, fifth decade of life. Um, this is just one paper that described two patients who were in their 40s and 50s who presented with seizures and sort of this paroxysmal weakness. There was a paper that came out yesterday from the group in Hungary. If any of you are on the call from Hungary, it was a good paper of a patient who was 50 in his 50s who had new onset seizures and was diagnosed with GA1. Um, Certainly, these are just some examples. The last time I did a literature review, it was double-digit patients over the age of 40 who were reported in the literature who had new onset seizures. So this can occur through life. We really don't know what the risk is for anyone. Um, Maybe I've talked to some of you, but as GA1 is more commonly on preconception screening panels of parents who are prospective parents. We've gotten a lot of calls of diagnosis of GA1 of these, 30 and 40-year-old individuals going through reproductive counseling. And we really don't know what the risk is for these things, just that they are there and that they do occur. The diagnosis of GA1, I'm sure that the majority of patients that you see in your clinic are diagnosed by newborn screening. Around the world, it's about 98% of patients are identified on newborn screening. Not everyone is picked up. We'll talk in a moment about the biochemical phenotype of low excretors, but they can sometimes be missed on newborn screening. Um, the biochemical testing we tend to do, we mainly look for elevations of glutaric acid, which is usually 10 times the normal limit of in patients with GA1, and 3-hydroxyglutaric acid, which is usually 3 to 4 times the normal limit. So it's usually less than GA1. And you can measure that directly in plasma or urine. You can see it semi-quantitatively in organic acids. Um, I briefly mentioned this idea of low excretors. I hope people have heard of that term before. But what happens in low excretors is that you don't excrete as much glutaric acid in your urine. That's why we use the term excretor. In fact, in these patients, it's not unusual for glutaric acid to be normal in urine, but you should still have abnormal amounts of 3-hydroxyglutaric acid. There's two definitions in the literature. The one is someone who has glutaric acid that's less than 100 millimole per mole of creatinine. That's a normal level, by the way. The one that I was taught in Dr. Goodman's lab is that your 3-hydroxyglutaric acid level is now higher than your glutaric acid level. So those two have sort of switched places. And again, you should still have the same amount of 3-hydroxyglutaric acid, whether you're a low excretor or a high excretor. We have a natural history of GA1 study ongoing, thanks to those of you who referred patients to us. We've actually just seen a couple of patients for the first time who have normal levels of 3-hydroxyglutaric acid. This is something that, looking back in Dr. Goodman's history of his lab, we've never seen before, but I guess just that I think biochemistry is really, really good for this disorder, but not perfect. The high excretor and low excretor genotype phenotype correlation is pretty good biochemically. It's hard to tell based on enzyme testing. This is a mix of enzyme testing done in skin fibroblasts and in leukocytes from a couple of different labs. But you'll see that there is some overlap here. Like on the one on the left, you can see that low excretors usually have an average or a mean level that's higher than the high excretors, but can have absent enzyme activity and vice versa. So these variants that I'm talking about, it's really about how much glutaric acid and 3-hydroxyglutaric acid they excrete. It does not equal enzyme activity. Most importantly, there is no correlation between being a high excreter and a low excreter by the amount of 3-hydroxyglutaric acid you have in the urine, by how much enzyme activity you have, and the risk of striatal injury. And that's so, if nobody remembers anything I said ever except that, that would be great. As an example, I think in the US at least, those of you who are here, um, know that in the Lancaster Amish population that they have really great studies describing the previous risk of striatal injury. And so still today, some kids in Lancaster do unfortunately have a striatal injury. And that common mutation in the Lancaster Amish has some of the highest residual enzyme activity ever measured in the lab. And as a young graduate student, I was always so shocked that you could have that much enzyme activity and still have such a devastating neurologic finding. So again, no correlation between risk of striatal injury at this moment in 2026. There is no way to predict whether a patient has a high or low risk of striatal injury. They all have the same risk. I think I said that too many times. Um, Genetic testing is also really good to diagnose GA1. Here's just a schematic from 2 years ago of all of the variants. And the only reason to show this is that there are a lot. There, again, no genotype phenotype correlation between severity, much different than NKH, what we started this talk on. There are no variants on this list that anyone would go, oh, that kid doesn't really have a risk. You don't need to do any treatment with them. They all have the same risk. Um, I think GA1 is one of the poster childs for consensus guidelines. I think our PDE guidelines were our third consensus guidelines, and I don't know how many GA1s there have been, but a lot more. The most recent one here from Nicholas Boy's group about guidelines for treatment of GA1. The most important treatment is that emergency treatment during that risk of decompensation, especially in the first 6 years of life, that could result in the striatal injury. Um, Treat any illness, any fever needs to be treated aggressively and promoting anabolism. Here on the right is a nice paper of odds ratios of your chance to get a striatal injury based on how quickly you respond to an illness. So, not surprisingly, the more aggressive you are in treating an illness, it seems as though the lower the risk of striatal injury. It never goes to zero. This by itself doesn't go to zero. But certainly, this is the most important thing that any clinician can do for a young GA1 patient is to treat any illness very seriously and quickly. The second thing that's recommended for all patients is to give lifelong carnitine supplementation. Two reasons. One, you can end up with a secondary carnitine deficiency, although I always caution all of us that when we measure carnitine, especially if we're just measuring plasma and not in urine, we're just measuring a tiny, tiny bit of what really carnitine is there. Most of the carnitine is in our tissues. But the other thing is that that carnitine will bind to what we believe is the toxic metabolites, and you will excrete your glutaric and 3-hydroxyglutaric. And that is the real reason you want to give the lifelong carnitine supplementation is to excrete those potentially toxic metabolites, and also to, in case you have a secondary carnitine deficiency. In the guidelines, the nutrition therapies differ based on the age of the patient. We started this talk about how the striatal specific injury is highest is there before age 6, and the striatal injury is not there after 6, and that is why there is a change in the diet recommendations. Pre-age 6 recommendations for a lysine-free formula, not protein restriction, but a lysine-free formula. Post age 6, the diet is recommended to focus a little bit more on low protein, or as they put in their paper, protein control. I actually never know what the words protein control means, so maybe I'm just interpreting that as low amounts of protein. We know that not everybody follows those guidelines. This was a paper led here in Colorado by Lori Bernstein and a group of us that just surveyed metabolic dietitians from around the world. And the real question was whether how many people actually liberalize the diet of patients with GA1. Surprise, a couple people said they did starting at age 3, although again, the risk of striatal injury, an initial striatal injury is till 3. The other thing is that not everybody changed the diet after age 6. And again, we know that there are neurologic problems post age 6. The question just is, do our metabolic nutritional therapies help those findings? And I don't think anybody really knows the answer. Um, One thing my soapbox here, this is not endorsed by Pete or anybody else, is that I think we often say that when a patient has a striatal injury, it's because parents didn't follow what we said close enough, and that drives me a little crazy. But this paper also suggests that adherence to metabolic treatment is closely correlated with outcomes. I mean, if this many families are struggling with our recommendations and there's still 10 to 30% of patients have a striatal injury, I think it just suggests how incredibly hard adherence is and that new treatments are really needed. I also even question whether that is true. It feels terrible to have push the blame onto our parents. I think as a community, what we can agree is that this is a crappy disease. And even though we're doing our best, our parents are doing the best, everyone's doing their best, sometimes bad outcomes occur because it's a crappy disease. And we do better than we used to 30 years ago, but we still need better options for patients. Um, I say this 10 to 30% a lot, and this is again active part of our research at the moment, but this was a survey that we just did for patients that's in review at the moment, and just how often patients are having neurologic injuries. And it was really surprising the number of parents who described their kids as having neurological damage, movement disorders, dystonia, um, speech problems, psychomotor problems. I just again want to remind ourselves that although we've done an amazing job in lowering that rate of striatal injury from 90% lower, this is still a crappy disease and we need to do better. And I like to say, I hope that we're going to do better for both. I want to end with some positivism and hopefully not too much biases as I've been involved in a lot of this work, but there's some really exciting therapies coming for both of these disorders. And I'm grouping them together because they're both within lysine metabolism. And I was honored to just be a small part of this group called Charlie in Europe, which was focused on developing new therapies and preclinical models, mainly human cell models and mouse models and a little bit zebrafish of these two disorders. This is a paper of ours from last year, led by Claire Van Karnebeek, where we took a mouse model of PDE and we knocked out what we think is our therapeutic target for all of lysine metabolism, so represented by these two X's here. And on the left, you can see we normalized all of the abnormal metabolism associated with PDE, suggesting that this might be a really good therapeutic target that maybe could replace our current dietary therapies, maybe even our B6 therapies. Another group that wasn't us, this is a really good paper actually out of the group out of China, amazing paper. They showed the same thing, that they were able to completely rescue the seizure phenotype and did a little better work than us, showed that it dramatically improved the cognitive testing in their mouse model. Um, our colleagues, this is from Sander Hooten's group in New York, that showed a similar thing for a GA1 model, that by targeting this first step in lysine metabolism, we could improve all of the abnormal 3-hydroxyglutaric and glutaric acid that occurs in GA1. Um, those are the most important results right there. And then another colleague at Duke, Dr. Dimi Bisick, also looked at this target for GA1 and was able to not only improve the biochemistry, but also rescue survival of his GA1 mouse. If these mice die when you feed them very high super physiological doses of lysine. And when he targeted this first step in lysine metabolism, none of the mice died and none of them develop these very classical vacuoles in the brain that we think are associated with the disease process. So that is 5 different groups I think I showed in those pictures, all suggest that that first step in lysine metabolism might be a druggable target. There are so many ongoing studies using different ways to drug that to target that. Stuff that we're doing in our lab, colleagues around the world are doing, and we're really excited that maybe there'll be ways to treat both of these disorders at the same time. Of course, gene therapy is something we've all talked about since the 90s for our patients. There's a couple of gene therapy approaches that have been published. This in a human cell model, which was able to normalize GA1 activity in the human cell model. This one from China in a GA1 mouse model, and this is currently an open clinical trial enrolling patients in China for this gene therapy for GA1. It's been ongoing for 2 years now, um, and again, just showed that the gene therapy was able to rescue survival and biochemistry. So I wanted to end on some happy notes. I think that both of these disorders are, we've done so much better in diagnosing them and trying to understand what their phenotype is to try to improve treatment. Both still need better treatments, and hopefully one of these talks will just, one of these years, will say these are the clinically available treatments for both those disorders. So I ended a few minutes early. I don't know if there are any questions, but happy to take any.
Yeah, there were a couple that popped up in the chat. Thank you, Dr. Coughlin. That was great, great review. First, I'm going to go in order where they came in, but they sort of bounced around in terms of who was responding to who. But Dr. Ford asked about, so she said that 6-oxo-PIP has a patent, so her lab's developing and validating a method to measure pipicolate and 2-oxo-PIP, or sorry, 2-OPP in dry blood spots. This is for PDE, obviously. Uh, I don't know if you can see it. We've not been able to clinically validate due to lack of PDE patient samples. Does 2-OPP alone have a good diagnostic uh, performance?
Yeah, Dr. Ford, great question. Be happy to talk to you about that patent and ways that we could support you because it is our patent, but other people, it's not 6-oxo-PIP that is patented, by the way. It does seem to be that 2-OPP is a really good diagnostic method on its own. There are some false positives and false negatives if you use that, depending on what method you're doing. That's why adding both biomarkers will increase your sensitivity and specificity. If I had to pick one to use in a dry blood spot, I would pick 2-OPP if that helps. But be happy to talk to anybody who's interested in it. We also have a 7-site prospective study going on about PDE, newborn screening, and always excited to have more partners.
Dr. Chang asked, does P6C or 6-oxo-PIP normalize with pyridoxine treatment?
Neither normalize with pyridoxine treatment. Interestingly, pipicolic acid can normalize with B6 only. We don't use that a lot as a biomarker because it normalizes really quickly and because it also is obviously a biomarker for other conditions that we like peroxisomal disorders. If you put patients on a lysine restrictive therapy, you can normalize P6C and 6-oxo-PIP. You got to really be on a restricted diet. You're really squeezing all the lysine out there. I don't think that that's the expectation. In general, what we expect is that those values will be decreased by about 70% of pre-treatment level. We have an ongoing study that's trying to understand like what truly should be the therapeutic target for these disorders, but they can normalize on diet. It's really hard, and most patients it's just significantly lower than pre-treatment.
Thanks. Dr. Williams had an interesting observation, and I think it's one that we've seen here, at least rarely, but it happens. He had a case where a patient who presented at 3 months from CPS custody with GA1 had initial striatal injury, but had some improvement in neuroexam with anabolic therapy. I don't know if you can comment on that. I think that was probably in response to these are permanent injuries. I could say just anecdotally, we've seen a couple patients who have had some turnaround both in MRI and in neurologic function clinically, but it seems to be the minority.
Yeah, there's if you look at old versions of Soderbergh as well, they'll talk about this like period during your crisis that you have the opportunity to reverse symptoms. And that has been shared anecdotally for a few people. So like you're in the middle of a crisis, you're seeing some dystonic movements, you're really aggressive with anabolic therapies, and that patient turns around and doesn't have long-lasting damage. You're absolutely right, Dr. Williams. I think when I said long term, it's sort of like post the injury. You know, you're discharged, you have, and there's no, you're outside of that crisis. We haven't seen a lot of therapies that have helped. There's been a few reports of deep brain stimulation, more theoretical of how that could help patients with GA1. There was a talk at SSIM about 5 years ago on the use of it, but it really hasn't seemed to be very beneficial. Um, but that window is so important. So when you're aggressively treating patients during the crisis, it's not like, oh, they're on the way to the hospital, but they're dystonic. We might as well turn around. There's still really a window of help there. And I think, is that what you were referring to, Pete? Sort of like those in the crisis moments.
Yeah, and I feel like the patients that I've seen turn around, which again are few, have had mild symptoms during the crisis. The
Mhm.
ones who have not been able to turn around are kids who have had severe hypotonia at the beginning of the crisis, seizures because of mass effect of swelling of basal ganglia during the crisis, and then this progressive, after that severe hypotonic, altered mental status period, progression of dystonia after like 3 or 4 days to very severe and not reversible. But yeah, I think there's some shades there of how severe the damage is during the crisis, and some of that I think could possibly be reversible.
Yeah, and I think you brought up a good point, and I'll talk about the possible non-accidental trauma things that also occur. I know that the group in Baylor in Texas, which I just wanted to see if you were on that paper. I don't see you on that paper, Dr. Williams, but it just published 2 weeks ago, and talking again about GA1 as a mimicker of abusive head trauma. I didn't love the word mimicker, but certainly that is something that people sometimes used to be diagnosed for more without newborn screening as they'd come in for the possibility of non-accidental trauma.
Great observation, great question. Another one that came in, Dr. Durar is asking specifically for adults who are newly diagnosed with GA1, how aggressive should you be with treatment? And I think that's a fantastic question.
Yeah, that one's been so hard, especially these like these adults diagnosed on the reproductive screening part. I mean, if you look at the guidelines, the recommendations are simply to give carnitine consistently, um, to oh man, I forget their wordings. Be careful with the amount of protein they eat. Do you remember what they call it, Pete? It's
A reasonable amount of protein intake.
yeah, a reasonable amount of protein, and to get MRIs done. I think the part that we've been, as maybe you can tell from our work on paradox-independent epilepsies, we're really interested in metabolic epilepsies, and the we haven't quite finished our analysis, but the rate of adults with epilepsy looks like it's going to be certainly well into the double digits. And so just to be thoughtful of the fact that patients can develop seizures all the way up into their sixth decade of life so far.
Yeah, and on top of that, the symptoms of headache and tremor and things like that, I don't know how much is affected by management currently, and it may be that we're just not being aggressive about it, but I feel like the few reports that we have haven't suggested that aggressive treatment will make a difference.
Some people have said they felt less headaches on carnitine.
Yeah, and that's it's easy enough to do, but
Hmm.
making a restrictive diet, that's a little bit more difficult. That said, patients that we have who've gone from children to adults who we followed, we continue to be relatively aggressive in managing them. We've not been using arginine diets. Not unrestrict, but loosen up around 6 years old. Usually talk to them about not eating too much protein that would contain lysine, but not restricting necessarily. But we do keep them on carnitine, and we do have an emergency letter and have them go in for fluids if they're having vomiting and avoid fasting over 12 hours. So yeah, it's a little bit different in how we're approaching, but maybe they'll tell us something in their natural history too as they start to get older. I mean, most of them are less than 20 still. Another question came through: is isolated subdural hemorrhage without macrocephaly or striatal injury still a presentation you've encountered in the GA1?
Certainly, without striatal injury, you can get this subdural hemorrhage. I think there are lots of clinicians who are worried about contact sports in these patients, or at least been providing recommendations. I assume that these patients also have macrocephaly, although I actually haven't looked at that.
So I did a deep dive because we've had a lot
Mhm,
of questions come in to us from our patients about can they do this, can they do that, can they water ski, can they go on
mhm.
a slide, can they, jump rope, whatever. Um, I feel like most of the reports of subdural hemorrhage have been less than 2 years old, and I don't think macrocephaly in and of itself was a predisposing factor, but it's more the space between the skull and the brain and those bridging veins that are going between and that shear force that could be there and the fragility of those vessels. So even if the skull isn't very large, if there's atrophy, frontotemporal atrophy in the brain, which we know happens too, that space is what actually predisposes to risk.
Yeah, the group, the Germans, I can put this in the chat if I can find it quickly, also have tried to show that there is a slightly decreased risk of subdural hemorrhage based on whether you're a high excreter or a low excreter, and the high excreters are slightly higher risk. So I'll just stick that in the chat right here.
Yep, I'll vouch for that. Great questions, great conversation. Thank you, Curtis, very much. That was a wonderful talk. Any other questions for Dr. Coughlin before we adjourn for the day? All right,
Thank you
folks.
all.
We have Dr. Starasta coming next week. He's going to be talking about glycolysis and carbohydrate metabolism. If you haven't heard Rodrigo talk, please come. He's a joy and fun to listen to, has some good insight. Thank you again, Dr. Coughlin. Great discussion and great insight into some of the research that's going on too. And thank you all. We'll see you next week.